Without further ado, the first speaker today is Dr. Eileen O'Reilly, who's a professor of medicine at the Weill Cornell College of Medicine. She's a medical oncologist, as Augie said, at Memorial Sloan Kettering Cancer Center. She's a principal investigator of multiple phase 1, 2, 3 clinical trials for pancreatic cancer, a real national, international leader at finding ways to better treat this disease that many of you are all experiencing. So without further ado, I'd really like to introduce Dr. Eileen O'Reilly, who's going to give us an update on the current state of treatment for pancreatic cancer.
Good morning, everyone. Thank you so much for the invitation. It's really a true honor and privilege to be here, and thank you very much to the Hirschberg family for inviting me and asking me to be part of this wonderful community. I'm just in awe of seeing everybody and all the wonderful resources that you have for this disease outside. It's very impressive, so thank you. So we'll go ahead and get started. I just need to acknowledge various disclosures in terms of research funding. And I have my back to the slide, so I'm just going to stand slightly to the side here so I can just see what I'm supposed to be talking about. So these are the topics, and I'm going to touch on a few different themes that various co-faculty members, Dr. Simeone, Dr. Herman, and colleagues will also touch on. But just to introduce a little bit of what's happening in the field of the epidemiology of pancreas cancer and what we're seeing with regard to change, to touch on some of the innovation that's happening in the metastatic disease space and some of the newer themes, and in particular targeted treatment, as hopefully you'll see that there's real progress happening and just on the cusp of, I think, very important developments in this disease that hopefully will translate into improvements in outcome for people. So to start with the epidemiology, and just a reminder for us all that this is a somewhat uncommon malignancy, but both nationally and internationally, this disease is increasing. And this is in fairly sharp distinction to other major malignancies like lung cancer, like prostate cancer and colon cancer. Pancreas cancer, about 1% increase per year. And these are the numbers, about 500,000 people worldwide with this malignancy. And this change happened in the sort of 80s, that this increase in incidence has been seen. And so it's, as we drill into the details a little bit more, just want to define what we're talking about. So most people, when they're diagnosed with this disease, will be in their 60s, 70s, and 80s. But like with other malignancies, in particular colorectal and esophageal cancer, we're seeing an increase in younger people with this disease. And the definition of that is people less than 50, but like everything, it's a continuum, and this is not a sharp division. So just briefly walking through this graph, if you look at the green box that looks at pancreas cancer, the top part is the incidence in people less than 50. The blue line being women and the green line being men. And the bottom part of the set of graphs is incidence in people greater than 50. And you can see it's relatively flat as we get older in terms of the incidence, although most people are older when they're diagnosed. But there's this increase in younger people, and in particular in younger women. And it's not really clear why that's happening, but there's a lot of focus in trying to understand this. And this is from a paper that was looking at just this changing epidemiology and incidence of pancreas cancer across multiple GI malignancies. And things that may have some potential for reversibility are highlighted here. So, for example, lifestyle considerations, and it's well known that pancreas cancer is contributed to by about 1/4 of the risk from smoking. So for people who have family members with this disease or have genetic considerations in their family, we know that not smoking is very important. Maintaining a healthy diet, maintaining a healthy weight, limiting on alcohol. Some of these may clearly impact on population basis. It's always harder on an individual basis, and some outcome improvements have been associated with these changes in particular related to pancreas cancer. And there are a lot of other things that are mutated. Maybe it's part of what we ingest in our diet, possibly the whole microbiome situation, possibly antibiotic use. A lot of things have been mutated, but for the most part, it's really not well understood why we're seeing these changes. And to impact those changes, we need to understand. So this is, considered to be a little bit of a worrisome trend in pancreas cancer, and a lot of focus, and I know some of my colleagues, again, will pick up on these themes. So when we look at younger people with this disease, what are the differences? I think there's two things from the genetic perspective. We see slightly higher incidence of genetic predisposition to this disease. It still doesn't account for most people diagnosed with this disease. And when we look at the tumor-based analysis, and we'll come to this in a little bit more detail in a few minutes, we see less KRAS mutations, suggesting that there may be some differences in terms of how the disease is developing over time. And consequent of both of these things, there are some therapeutic opportunities that we think about in particular for younger patients diagnosed with this cancer. So this is an analysis from a large database, trying to, again, understand, are there outcome differences for people younger than the age of 50 relative to those that are older? And perhaps not surprisingly, the suggestion is yes. And maybe that's because people tend to be a little bit healthier otherwise in terms of less other chronic medical conditions, perhaps related to some of the treatment impacts, but that's really not well understood. And again, a very active area of exploration. So just summing up on this part, this disease is increasing in incidence. Part of that related to genetics, but mostly not, and mostly not well understood, and multiple lifestyle factors under close review here, and some opportunities for public health prevention measures, but a very, very ripe and important area of ongoing research. So moving now to treatment aspects of this disease, and just to highlight what we kind of alluded to first about what germline means and what somatic means. So germline is in all our cells in the body. It's something we're, for the most part, born with and inherit different sets of genes from our parents that make us unique. And for pancreas cancer, we know that about 10% will have a genetic predisposition. I'm going to be mostly focused on the somatic aspects of this, and this is findings or genetic changes that accumulate in the tumors directly that are not inherited and don't run in families. And again, there are treatment implications of this. So a lot of information on this slide, but I would say a decade ago, this was a very short slide and primarily from the treatment perspective limited to chemotherapy. But we're now thinking about changing this disease in terms of how we think about it from the treatment perspective into KRAS altered disease. And again, we'll come to what that looks like in terms of what's happening. A subset of patients who don't have a KRAS mutation, again, KRAS being unique to the tumor, not in the bloodline, and a number of different options there. And I will note that there's a number of regulatory or FDA or guideline endorsed approvals in this setting, mostly on the basis of data in other diseases, but because these genomic alterations occur in pancreas cancer, there are approvals for this disease specifically as well. So again, we look hard to find these alterations. And we'll spend a little bit talking about the treatment aspects of BRCA and homologous repair deficiency and how that applies in the clinic. But just to highlight two different themes in the sort of realm of standard therapy and what's happening. So primarily a chemotherapy-based disease in terms of treatments with combinations of FOLFIRINOX, which is 5-FU, oxaliplatin, irinotecan, and leucovorin. There's a related version of that called NALIRIFOX, which substitutes a nanoparticle formulation of irinotecan, which may lead to higher levels in the tumor itself and higher levels circulating. So theoretically may have some advantages, although not been compared directly. And this particular combination was compared to gemcitabine and nab-paclitaxel, another FDA-approved guideline-endorsed treatment in advanced disease. And bottom line, and there are two, I think, important outcomes from this study, is that it led to an approval. This happened at the end of February for NALIRIFOX as a new treatment for a person with a new diagnosis of metastatic pancreas cancer. So that's one thing. The second thing that it suggests, and this is all consequent on individual treatment person tailoring, that for an average person who has a good level of health aside from their cancer, that using either FOLFIRINOX or NALIRIFOX may be a preferred approach over gemcitabine and nab-paclitaxel. I say this maybe because the trial was positive in this regard, but there are some newer markers that are being looked at in the genetics and in the pathology of the disease that can suggest that for some people, actually, gemcitabine and nab-paclitaxel may be a preferred approach. That's all still under active investigation, but it's nice to see new approval, and this is a landmark in a way because it's been a decade since we've had a disease-specific FDA approval outside of a small genetic context in this cancer. So one other thing that comes up commonly in the treatment of this disease is we know that chemotherapy works, but we know it can be intensive on the body in terms of fatigue, in terms of neuropathy, right, pins and needles and numbness, in terms of blood count suppression and just the blahs over time for a lot of people. So this was a study that was presented at our GI cancers meeting earlier this year that provides data for what's been done for a while, but it's the first time we have what we call prospective or high-level data, suggesting that de-intensification of treatment, so moving to a more maintenance setting, so dropping one drug, for example, preserves outcome and can decrease side effects and impact favorably on quality of life. So this whole theme of maintenance therapy is becoming a big one in pancreas cancer in a number of different settings from the genetic perspective, but also aside from any genetic alteration. We look to see if we can start to do this, and not just with chemotherapy, but with other treatment approaches that may lead to less discomfort over time. And I don't want to steal Dr. Herman's thunder because I know he'll be discussing this in a little bit more detail, but this I think is a very interesting concept, and I think it's an important one, and it's one we're going to see a lot of building off as we develop this theme. And this was a study that was conducted from the group at MD Anderson for individuals who have metastatic pancreas cancer, and I'll just stress the metastatic here. A selected group of people who were allocated to either continuation of chemotherapy or chemotherapy and integration of a local treatment, and the local treatment here being primarily radiation. And without getting into all the details on it, and there are a number of caveats in terms of the design, etc., but I think the observation is a very important one and gives us a precedent now for developing this in pancreas cancer, is that for selected people, that the addition of a local therapy to their metastatic disease, and in this, again, context radiation, that seemed to improve outcomes. Now, this doesn't apply to everybody, and it's all about the individual, but the more we can get into tailoring treatment for individual people, I think the more better our therapies will be and greater impacts in terms of quality of life. So more to come on this, and I think it's a small study, but a very important one. So summing up here with regard to standard therapy and where we are in 2024, we have 3 different chemotherapy programs that are FDA and regulatory approved. We have this concept of maintenance therapy, which is de-escalation, so dropping certain drugs, for example, oxaliplatin, which can contribute to a fair bit of discomfort. Nonetheless, it is an important drug. And then building on standard therapies and integrating local therapies, be it ablation, be it surgical-based approaches for selected people, and potentially radiation for selected individuals. So moving now to the topic of genetic targeting in terms of how this applies. And this is an analysis from a large cohort of individuals who'd undergone genetic testing for multiple different malignancies. And the point being here that relative to other diseases, we see a relatively high frequency of alterations in the bloodline that can predispose to pancreas cancer, BRCA2, BRCA1, ATM, PALB2, and a series of others. So it's routinely recommended, and I realize it's well known to this audience that everybody with this disease has that genetic profiling done, both in terms of the bloodline and also, and I would argue for every stage of the disease, in terms of tumor-based testing as well. And there are multiple models, and we'll hear more about this later on, but I think what's revolutionized being able to do this in practice for pancreas cancer is what's called point-of-care testing. So for us as individuals looking after people and families with this disease, being able to test in the clinic, and then if we identify a positive finding, have our colleagues who are experts in genetics and genetics counselors discuss in detail what that means for the person and what it means in terms of their family and what the other applications of that data is. So this is relatively new, but it's been a very key thing in this disease. So a lot of information on this side, but just to call out one thing, when people have a BRCA alteration in their, either in the bloodline, these can occur in the tumor as well, we know that particular classes of drugs and platinum drugs have a high ability to shrink the cancer. This is this plot on the left. It's called a waterfall plot, and all those lines down are good, meaning that the cancer has responded. So we see that to a higher degree relative to unselected pancreas cancer, so using either cisplatin or oxaliplatin, or indeed maybe other platinum-based agents, we think is an important step for people who have these genetic alterations. And then when people do have a BRCA alteration, there's a selective vulnerability in the tumor cells themselves that make them uniquely sensitive to both platinum drugs, other DNA damaging approaches, and in particular something called PARP inhibitors, which are a class of oral drugs, one of which is approved in pancreas cancer and another of which has guideline endorsement. And this came about consequent of this particular trial. This was a large phase 3 trial published and presented a couple of years ago now that screened people for germline BRCA, so in the bloodline. These individuals received initial platinum-based therapy in the setting of metastatic pancreas cancer. Their cancer was either stable or shrinking, and then were randomized to one of these oral medications, here olaparib, or being observed. And this led to olaparib having higher ability to shrink the cancer and to control the disease. It didn't impact on the length of time people lived, and there's a lot of questions about that, possibly related to the size of the study. But this is just a real-life example, and this is a lovely lady, and this is a still ongoing story now, almost 9 years in, just to illustrate what we're always hoping will happen to the person in front of us with metastatic pancreas cancer in terms of liver involvement, in terms of lymph node involvement, quite sick a presentation with a lot of disease. You can see that referenced by the CA99, and when we see these responses, they're just so extraordinarily gratifying for everybody, just in terms of the cancer shrinking and just that flat line in terms of CA99 for a very, very, very extended extended period of time. We want to make this translatable to everybody, and we're not there yet, of course, and we still don't understand why, for some individuals with BRCA, we'll see these extraordinarily favorable outcomes, but yet not with others. And that's a big part of work that's underway in multiple institutions. So again, a lot of data on this slide, so I'll just summarize, just to want to mention that there are three big questions being asked in terms of national studies in this space. One is if we can bring PARP inhibitors up to earlier stage disease, so after people have had surgery and completed their adjuvant or postoperative therapy in the setting of BRCA, does adding a PARP inhibitor better outcome? That's ongoing, it's led by one of our colleagues at Penn. A national study in the metastatic space is building on that trial POLO, which led to the regulatory approval of olaparib, and asking, can we add immunotherapy to that, and will that control the disease for longer? And then another question is, if we switch the platinum drug after an initial period of benefit or not, is that going to lead to improved outcome? So if this resonates with anybody in the audience, these are important trials if you, your family, or friends or colleagues are touched by this disease. So summing up with regard to this part of the talk, genetics in terms of BRCA1, BRCA2, and PALB2, if we include both tumor-based and bloodline origin, it's about 5 to 8% of this disease. So it's a, it's a small subset, but it's a very important subset that we have specific treatments that we apply for this group of individuals, and a lot happening, building on bringing these drugs to earlier stage disease, adding immunotherapy, switching up the combination of medication. So I'm going to switch topics again and speak to KRAS. And again, I realize there's a lot here, but I'll just summarize the importance of this. So going back to tumor-based genetics, about 88 to 90% of people will have an alteration in KRAS, and it comes in various flavors. Most common in pancreas cancer is something called KRAS G12D, followed by V, followed by R, and highlighted G12C because that's at the moment where we have regulatory approvals and drugs available for use in the clinic, but that's a small subset of individuals with this disease. And why is this important? It's important for two reasons. Whether one has a KRAS mutation or not, we know for people who do not have a KRAS mutation, and we mentioned that this is a little bit enriched in younger people, there may be other genetic factors in the tumor that are underpinning the development of the tumor and for which we have therapeutic opportunities. And for people who do have a KRAS mutation, we know this speaks to somewhat less favorable disease biology, and that's been known for decades. But what has changed is there are now multiple drugs in the clinic, some there already, and many more coming, targeting various aspects of this important signaling pathway in pancreas cancer. It's involved in the fundamentally in the growth, in the development of this disease, in the metastatic potential of this disease. And right now we have kind of a queue as we try to get this all scaled up in the field. But this is where kind of there's significant excitement. And this list is already out of date. And I just show it not to, again, to illustrate the individual drugs, but just to illustrate the wealth of potential that we hope exists in this space for pancreas cancer and the different ways that KRAS can be targeted directly, indirectly, tackling the protein, tackling the gene itself, tackling the different versions of the gene, combining it with other things. And in the setting of KRAS G12C, we said that's about 1% of people with pancreas cancer. We've had 5 different data sets with different drugs, and they all show the same thing, an ability to shrink the cancer and to control the disease. So again, we look hard to know what type of KRAS mutation is present, if there is one present, and right now 2 of those are in our guidelines and available for use. Having said that, the more common versions of KRAS, we have limited data yet that has been publicly presented, but this is one. Once more, this is a waterfall plot and just showing all those downward lines. So anything that's downward is a positive thing, and in this setting of pancreas cancer, which has been heavily treated, to see the ability to shrink the cancer and control disease is very exciting. Having been in drug development for a while in this disease, it's not that common that we'll see this. So the hope once more is that this can be integrated into earlier stage disease and combined with other things. And there are a lot of different potentials for combinations. So combining very narrow, what we call allele-specific inhibitors, so targeting one version of the gene with a broader, what we call pan-RAS inhibitors, that's one strategy. Combining with chemotherapy, combining with immunotherapy, combining with radiation and other modalities. So again, a lot happening in this setting in pancreas cancer. So building on that, just going to a couple of slides on immunotherapy and vaccines in this disease. So we've known for a while that for very, very select people using T-cell-based approaches, so one component of our immune system, that we can target this disease. However, these are highly, highly customized approaches and not necessarily scalable for most people. And they're predicated on a specific version of the gene in the tumor and a specific tissue type that's called HLA type. And when you put those two together, it amounts to a relatively small percentage of people. But just the fact that this can be done leads to a whole potential of opportunities. And in pancreas cancer, there's been shown in selected people an ability to shrink the cancer with immunotherapy. So this is one vaccine that we've worked on with many colleagues around the country, including our collaborators at UCLA, looking at putting KRAS as a direct target in a platform-based approach where you can slot in a way of boosting the immune system and delivering this vaccine as a subcutaneous injection into the arms and into the legs. It's given weekly for 4 weeks and then every other week. And this was done initially for a group of individuals who had had surgery, had completed their standard treatment, but had either one of two things, had rising tumor markers, so something like the CA19-9 or CEA was increasing, and or had detectable ctDNA, so all suggesting that this group of individuals might be at risk for future evidence of their cancer being apparent. And this was given as a very common strategy that's used in the infectious disease world of priming initially with a vaccine, so getting the immune system primed and optimized, and then at a later time point coming back and boosting with additional vaccines. And in this setting, again, a lot of data here, so just to explain the 2 points, that there was an ability to generate a very potent immune response, and that's kind of a necessary prerequisite to seeing a signal in terms of any anti-cancer potential. The second thing that was shown that for selected individuals, and these were people with both colon and pancreas cancer, although mostly had pancreas cancer, that there was some clearance of ctDNA, that circulating microscopic marker that suggested apparent disease, and reduction in tumor markers. Again, all early. And that led to the observation that people who had a very specific and potent immune response, that there seemed to be a delay in terms of their cancer coming back. So again, we can't over-interpret this signal, but it provided a lot of support for going on to develop this trial, which is actively underway. And this is for individuals with pancreas cancer who've completed surgery, who have completed all of their standard therapy, sort of agnostic to the specifics of that, as long as they're without activity of the disease, randomized to vaccine or not. And then this is targeting all of the common versions of KRAS that we know to be present in these tumors, with a possibility, if it makes sense, both from the medical perspective, etc., for crossover for people allocated to the observation arm. So more to come on this, and we'll see how all of that pans out. So additional work in the vaccine space was led by one of my colleagues at MSK, Dr. Vinod Balachandran. He's a surgical scientist who made an important observation, along with many others, that people who fare well with pancreas cancer after surgery appear to have an enrichment in terms of specific T cells in their tumors, in their blood, that can be identified many years later. And the question there was, can you capitalize on that, and can you immunize a person with a customized vaccine to try to generate this immune response to see if you can improve outcomes? And this was a small study that we commenced and completed during the pandemic, where individuals with pancreas cancer who went to surgery had their tumor profiled using 2 different methods of genomic detection to identify the 20 most promising targets in their tumor. And that was made into an mRNA-based vaccine. And at that time, mRNA vaccines were not being used for cancer, so it was one of the first. And first question was, can you do this? And can you do this in a time frame that's feasible? And this is a pretty complex and labor-intensive and resource-intensive consideration, but it was shown to be feasible and to be able to be integrated with standard post-operative therapy with FOLFIRINOX. And similar to the other vaccine approach, the observation was that people who generated a very potent and specific immune response appear to have delay in terms of recurrence of their cancer, and in some settings, non-recurrence of their cancer. And that's been translated into this study that Dr. Donoghue was just telling me has just opened here as well for people with pancreas cancer. So a different approach, customized approach. The other is also tailored, but it's sort of an off-the-shelf, whereas this is done very specifically on an individual person basis, and being combined again and sequenced with standard treatment in this disease. So a couple of last slides, and then we'll sum up. So what about this setting of KRAS wild type? Are there opportunities for treatment? And as we said, this is slightly more common in younger people, about 10, maybe 15% of people there where we don't see a KRAS mutation. And we know from this study, this was conducted in China, that if we combine targeting approaches to the KRAS wild-type setting, that we can lead to improvements in outcome for this grouping of people. KRAS wild-type is a kind of a mishmash of a lot of different subsets of genetic findings in there. And this is one example of why it's important. This was a young man who had come to us, and he had had metastatic disease for a little period of time. He had had 2 attempts to get tissue, and neither of them were successful. And we always struggle with this. Should we commit a person to another biopsy and invasive procedure with the downside? And aren't we so glad that we did? And just important that we have to look to find these alterations. He turned out to have no KRAS mutation, had something called an NRG1 fusion, and these are, again, other genetic findings that we see in this setting for which there are drugs that are not necessarily approved but available and accessible on selected individual basis, where we can see, again, striking disease control for an extended period of time with a good quality of life. So all of the reasons why we look for these lack of alterations in terms of KRAS. And then one more target that we don't really have any data to present, but just to mention, it's a topical one in that this is a surface marker that's present in a percentage of people with pancreas cancer. In stomach cancer, there have been two big studies conducted, both of which have been positive, targeting this alteration called Claudin 18.2, using this antibody. It's a protein-based treatment that's combined with chemotherapy. We're waiting for regulatory approval by the FDA in stomach cancer. That's anticipated to happen very soon. So a similar study in what we call a biomarker enriched, based on testing of tumor for individuals who have expression of this marker, has been completed in terms of chemotherapy plus antibody compared to chemotherapy. This will read out, we hope, end of this year, probably early 2025. And there's some optimism that this target will prove to be an important one and one that's clinically meaningful. And so stay tuned to this. There are other approaches in the clinic targeting this, all in terms of early phase studies. So I'll sum up, a lot happening in pancreas cancer, and this doesn't do justice in any way to the field, but just picking out selected topics that are directly, we think, going to move the field forward. So we've had a new approval in 2024. That's an important thing. The topic of maintenance therapy is now kind of rising to prime time in pancreas cancer. A lot of drug development starting to happen in that space. Genetic-based treatments are real. They're here today for a subset, some of which are relatively rare, but absolutely coming for KRAS, which is not rare at all, and which, as we said, is critical to this disease. And a lot of emerging therapies and different ways of targeting using things like antibody-drug conjugates. These are ways of combining a chemotherapy with a targeted medication in one molecule, using what's called bispecifics, so something that targets the immune system and targets the tumor. These are, again, actively in development. And most of all, just to say thank you to you all, and thank you to all of our colleagues and to the Hirschberg Family Foundation. Thank you.
Dr. O'Reilly, great talk. Will Go, Chief Medical Officer of A2 Bio. Just wanted your thoughts on Claudin 18.2. A lot of other drug developers like myself are looking at this target. Questions and what modality do you think is best? ADCs, bispecifics? I'm a CAR T guy. And then can you get a therapeutic window before you actually have some kind of toxicity? Thank you.
Yeah, thank you very much. So there's multiple ways, as you're alluding to, for targeting this. And so the one that has completed recruitment is using an antibody-based approach, which is an intravenous targeting agent combined with chemotherapy. I think antibody-drug conjugates as a tool are going to be a very important one in pancreas cancer, and partly because of the heterogeneity of expression on the tumor, that you not just have a honing molecule to localize, but you also can leverage the combination of chemotherapy and antibody-drug conjugates, which I think may be very critical for this disease. We don't know yet. In terms of CAR T, I think it's another fascinating strategy using the immune system in solid organ malignancies. As we all know, that hasn't been an easy path forward, but we know that there is some signal in this space in pancreas cancer and stomach cancer in particular. So I think it's going to be a very exciting, I'm hopeful it's going to be a very important and clinically validated target for decision making before too long in this disease.
We have a virtual question. What would be the reason for using NALIRIFOX therapy versus FOLFIRINOX?
Yeah, so thanks very much. That's a very good question and a very common question. So maybe just to set the scene for this, FOLFIRINOX has been around now for almost 12, 13, 14 years in pancreas cancer. NALIRIFOX is kind of the newer version of this. So there are a couple of things that are different. One is the formulation of irinotecan. We mentioned that this is a nanoparticle formulation. Theoretically, it may have some advantages, but it hasn't been compared directly head-to-head, so we don't know that. The second thing is that the oxaliplatin dosing is lower. And personally, I'm a big fan of lower oxaliplatin dosing for two reasons. I think it is more comfortable for people, and two, we may be able to stretch it out a little bit longer, which can be important in terms of this disease. But in terms of head-to-head comparison of these two, there is no head-to-head. And I think we're just delighted to have more options in pancreas cancer. I'm kind of neutral on which to use, but I think they're both reasonable choices. We may start to see more building off NALIRIFOX because it has an FDA approval. Interestingly, FOLFIRINOX does not. It has an approval in every other sense of the word, but it was never actually vetted by the FDA because it was developed in a different setting. Yes.
Thank you very much for your wonderful talk. Could you discuss the side effects of immunotherapy or the T-cell-based therapy?
Thank you. So that's a great question, and not one that was emphasized in the talk at all is in terms of side effects. So immunotherapy is a very broad term, and I'll maybe mention something called checkpoint inhibitors, which we use to augment the signal with a lot of immune targeting approaches. And for those drugs, for example, something called nivolumab or pembrolizumab, Opdivo, Keytruda, those names might be familiar to some. For the most part, though, that class of drugs, and there are many of them, there's probably 20, 30 at this point, are mostly fairly well tolerated. I would say 9 out of 10 people will do well with those drugs. About 5 to 10% will have a mild, kind of moderate, or sometimes more severe immune-related side effect, where what happens is these drugs, they don't act directly against the they don't act directly on the malignant cells. They act to augment the immune system and have the immune system do the work against the tumor. So the consequences of that is you can have a very upregulated immune system that to some degree can be not well controlled, leading to immune-related side effects. So, for example, inflammation in the lung, pneumonitis, inflammation in the gut, colitis, maybe a common but treatable one, and these are all treatable, but is the thyroid getting underactive or overactive and needing medication. So there's a whole spectrum, some of them quite rare, and essentially any organ system in the body is vulnerable. Mostly the go-to approach is pausing steroids and other steroid-sparing medications to allay those side effects. So that's kind of one class of immune-related targeting. There are many other immune-related approaches that can very acutely, with checkpoint inhibitors, the class of drugs we just talked about, the time course is later, it's usually in months. But for some immune targeting approaches, we can see a very emergent immune-related profile of fevers, chills, drop in the blood pressure, etc. And there are a lot of measures that we integrate to support people to make those as tolerable and as least uncomfortable as possible. But steroids are a big tool of importance in addressing immune-related toxicities, but we try to spare them to mitigate any offset in terms of dampening the anti-cancer response.
Are there supplements or other things that patients can take or dietary things that they should consider when they're undergoing treatment, especially chemotherapy?
Yeah, thank you. Another great question, and I know we'll have a talk by one of the nutritionists, dietitianists a little later to speak to this. Yeah, I think nutrition is critical, and optimizing that in the very best ways we can. So small meals, lots of snacks, making sure pancreatic enzyme replacement therapy is being used and being used to its full potential. And that, I would say, is something that we see relatively commonly not optimized, and it's such a helpful tool when that is being dosed correctly in terms of not just comfort when one is eating, but gaining all the value from what you're eating and having that translate into useful calories. So that's really key. Lots of protein, a little bit less on the discretionary cakes, sweets, and biscuits, and more on the complex carbohydrates. In terms of dietary supplements, I think we're a little bit more neutral on those, not to say they don't have a value, but I think it's always in partnership with the current best therapy. Some supplements we worry a little bit about may have, counterproductive effects, and so I think it's always good to discuss with your medical team to make sure, one, they're aware, and two, if there's any potential concerns. But we try to do it as an integrated plan.
Hi. Do you have any advice or data on the use of long-term maintenance chemo?
Yeah, so thank you. So this question is an important one, and so just to kind of set the scene for this, after, for example, a person diagnosed with metastatic disease has an initial period of 4 to 6 months of relatively intensive treatment, and hopefully treatment is going well and there's an opportunity to de-escalate, and then question of whether to continue, to stop, and if one is to continue, what's the best choice of treatment. So I would say it very much depends on the person. It depends on what their cumulative side effects are. It depends on what the genetic context is. But for the most part, what we use in terms of de-escalated therapy tends to be less side effect incurring relative to the initial period of intense treatment. And for example, that relates in part to maybe stopping oxaliplatin in people who are receiving that because of the cumulative impact in terms of nerves, in terms of dexterity, in terms of pins and needles and numbness. But things like 5-FU, things like irinotecan, oral versions of 5-FU, they are all relatively well tolerated as single drugs or 2-drug combinations. In the genetic setting with, for example, PARP inhibitors, there's some longer term issues with blood counts and shorter term, and very, very rarely a very abnormal blood picture that can be worrisome, but thankfully and fortunately those are rare. Thank you.
Thank you so much, Dr. O'Reilly. A lot of exciting activity in this space. So much activity, so much stuff going on. I think it's clear that the treatment of pancreatic cancer has become increasingly more complex for all good reasons, and stresses the importance of why it's important to be treated at a multidisciplinary center like UCLA or Memorial Sloan Kettering or UC San Diego.